and they have some risk factors for developing diabetes or other metabolic diseases versus somebody who already has these conditions, either way, I'm going to probably start with the same approach to the patient in asking, as you guys have both alluded to, where they're at in terms of their lifestyle. So what is their lifestyle like? What is your diet like? Are you getting any exercise? How are your stress levels? Things like this, and then trying to focus with the patient on if there are any areas that they've been considering making a lifestyle change. So I'm a big fan of motivational interviewing, the idea that if we can get our patients to talk about what it is that, where it is that they might be stuck or changes they're considering making, and get them to vocalize where they see the barriers to making those changes, they're more likely to then be able to help give suggestions as to how they can move themselves through to making maybe the next small step. So I tend to try to break things down into smaller chunks with patients and see if there's one area of their health where they know that they need to make a change and feel that they're reasonably motivated to start change in that area. So maybe something as simple as saying, I know I need to eat better. Okay, what does that mean? I see patients all over the Portland, Beaverton area and further out, and some patients have a lot of resources and are reasonably healthy. Other patients are really, really unhealthy. So for one patient, it might mean I'm going to stop drinking a liter of Coke every day, because I know that's not good for me. Or maybe I've got somebody who's really pretty healthy, and they just, instead of working out 3 days a week, need to start upping it and maybe start doing some weight training in addition to their cardiovascular workouts. So it really depends to me where the patient's at. The only difference I would say is that when somebody does have a pre-metabolic condition versus already having the disease states, I always try to make sure to remind them that it's not inevitable for them to progress, but if they do everything exactly the same as they are doing it now, they are likely to go on to develop these diseases and have problems.
Like those who have preceded me, I have no disagreement with what already has been said. In terms of the differences in treatment for someone with frank advanced disease versus risk factors, I would say within my own scope of practice, it's probably going to be pretty similar, except I'm going to apply some extra intensity in my motivational efforts for someone for whom the stakes are higher because their situation is worse. That said, I want to question the value, and I want to ask all of you to question the value of a construct like pre-metabolic syndrome or various other pre-syndromes like pre-hypertension. The reason I question it myself and ask you to question it is that by accepting it as a real entity, we are, among other things, with the best of intentions, in my view, taking millions of people in our society, maybe tens of millions over time, who are basically healthy for the most part, but have some, lifestyle changes that they should make to stay healthy, and we are defining them as having a diagnosed condition. I think that affects, in a harmful way, our own conceptualization of our interaction with them. Perhaps even more insidiously, I think it plants within them the idea that they're sick rather than fundamentally well but need to make some changes. I think that difference in concept is incredibly important, and I'm going to limit, I know I've got a limit in time here, but I would like a show of hands. How many of you are familiar with the controversy that erupted last summer about the redefinition of the term hypertension from pre-hypertension? Okay, some of you have, some of you haven't. Since my time is limited right now, I will use my later time to get to that.
Thank you, Dr. Redwood. Is there any other discussion? Okay. We'll get moving on to the next question then. We have a limited amount of time. And something that I forgot to mention earlier is that everyone should have a note card or on your desk or somewhere near you. And if at any time during discussion you have a question that you just really want answered, please write that down. And there are members in the audience. If you are someone who's willing to pick up a note card, please stand for just a moment. Thank you. And so it looks like we're mostly on this side of the room, but just feel free to raise your hand or pass the note card to the side, and Rebecca's going around to the other side. So we'll have one person on either side, and we'll go ahead and have those passed down. And please do ask questions. I don't know if I have enough for the next 45 minutes. Moving on to our next question. And this time we will start with Dr. Chan in the spirit of moving all around. So, Dr. Chan, in your professional experience, what are some less obvious signs and symptoms that you look for to identify people with pre-metabolic disease? And in this question, we're not necessarily asking about hypertension, pre-hypertension. We're looking for less obvious symptoms.
I think as far as our society, or maybe personally, I don't know, maybe you guys can tell me what you think, but I think I've become more accustomed to seeing people who are overweight or obese. I feel like we aren't really, I think there's a lot of shame as far as, there's a book called, I think it's Healthy at Every Size, or I think it's hard for us to point this out to people that they are overweight or obese. And the BMI is not necessarily the best marker, as we know, in defining whether people are overweight or obese. It is the most commonly used marker. There's also a way to use waist to hip circumference to assess whether somebody is overweight or obese as well. I think it's hard to discuss this with people because there's a lot of people who have shame around this topic, and but it is one of the things that you know, while I was doing research, that somewhere close to 69% of people in the country are overweight or obese. So there's more people who are overweight or obese in our country than there are people who are healthy or normal weight. And the definition of this is a normal BMI between 18.5 to 25. So that, I think there's a lot of opportunity for us to work with this group of people to, you know, first of all, the second comment here is that only 65% of obese adults are, have been told that they're overweight. So then there's also a significant number of people that, despite being overweight or obese as a medical condition, are not told that, that they are. And then the third thing is that only less than 50% of people who are overweight or obese are actually told to lose weight. So I guess my approach would be kind of using this, and there's evidence that reducing weight by even 5 to 10% can reduce all of these risk factors, metabolic risk factors, lowering the blood pressure, lipids, glucose tolerance, reduces their risk of developing hypertension and diabetes. So that, I think that would be my approach, is kind of identifying that people are overweight and obese, and there's a big number of our population, and a big number of this population are not being told, and it's not being addressed by their medical providers to address this issue.
I'm not sure that I can think of any specific signs that are maybe important to pay attention to. Some of the symptoms, though, that I think of with this question would be always making sure, if I have a patient who's got obesity or is overweight or is struggling because their labs came back and it suggests they are pre-diabetic and need to make lifestyle changes, typically eating better, exercising more, losing weight, is to always make sure and screen them for signs of anxiety and depression, substance abuse, or other mental, emotional, even spiritual issues, where they're, because I find that a lot of people aren't motivated to make changes in their lifestyle because they don't feel well, and that's physically and emotionally. They don't feel well, and so maybe they need to connect with with somebody, a group of people, or something, a social work or whatever. That kind of gets into some of where we're going to head in terms of who we like to try to involve in care. But I think it's really important to not forget that when we're talking about metabolic stuff and we're talking about what are those, we're talking about all these basically risk factors for developing heart disease and stroke and having bad health outcomes, that it isn't in a vacuum. These aren't just physical problems. They're highly influenced by a person's mental emotional state. Also their level of pain. So I like physical medicine as a modality because a lot of patients, I think, are physically don't feel well, emotionally don't feel well, and it's not going to be, in my experience, beneficial to try to talk about making healthy lifestyle changes when they really are just struggling to get through the day, not feeling well on other levels.
I am really enjoying being on a panel with people whose perspectives I feel like I have so much in common with. What I would say, first of all, I don't really have an answer to this as to some esoteric sign that you should really watch for. I would say that I have seen many times, occasionally in myself in the past, but often in my students today, that there is a desire to look for the zebra rather than the horse. And I would encourage you to look for the major signs, while being aware that they don't always tell the whole story. That's my answer. I will yield the remainder of my time.
So some of the less obvious signs that I think are often mental emotional, especially swings of emotions, because and also, I would say, some type of chronic inflammatory condition that the person has. If they have those two kinds of things, then I would say there's potential that they're moving towards these kinds of things. The other piece that I would say, and although I think we can all agree that the obesity and those types of things are certain predispositions to that, I find that unstable blood sugar and dysregulation of blood sugar is global. It's not just rooted in people who are obese or overweight. I find that people who don't eat well and people who don't eat in general and skip meals and have a lot of stress and have a lot of kinds of these types of things that we are all in some ways have and are affected, because no one's immune to this, and also we're so affected by it that it's almost like we are immune to it, in a sense that we're immune that we even have it. There's student syndrome is kind of like this. Many of you are probably students. If you ask first-year students how they're doing, they'll tell you they're stressed out. If you ask second-year students how they're doing, they're not stressed out anymore, which seems strange that they're halfway into their education now. They're less stressed than when they started. I think they're just used to how stressed out they are, so they're no longer aware that they're that stressed. So I think it's something similar like this. If we don't regulate the metabolism, if the metabolism isn't regulated, then we are in a pre-metabolic type of situation where we are facing putting the body into a situation where it now has to make choices of how it's going to get through it. And so I think that is something beyond just the people who we would target and say these people have this. I think we have to really look, because I have a lot of patients who are not obese and who have what they would deem healthy lifestyles. They exercise, they eat relatively well, but you can already see in them the pre-signs of these kinds of things coming. Or they have chronic inflammatory things. They have dysregulated cholesterol. They have pre-hypertensive, separate from the discussion we were having about pre-hypertensive. They have those kinds of things on their horizon. So I think that we have to really see that picture as well. So there are the overt things, but mental emotional swings especially are one of the things that I look for. And then anyone that's got some type of inflammatory condition, pain conditions, things like this, where what's going on there, why is the body reacting this way, right? That's the things that I start to look for. Then when you see those people, you get with them with their ND or their MD or their labs, you look at that and you can see, oh, maybe their labs are, quote, normal. But if a normal lab is between 10 and 50 and they're 10, then they've been told they're normal. But that's not really normal in the sense of actual normal, body normal. Plus, you have to look at everyone as an individual. What in this person isn't bothering them, in this person, they have a major problem going on. So I think those are the kinds of things that we have to look at from as less obvious signs.
Great. All right, we'll move on to the next question. So when you first diagnose a patient with pre-metabolic syndrome, what types of practitioners do you initially think of contacting for an integrative approach to treatment? Or if you're not the practitioner that diagnoses the patient, who do you find calling you in for treatment? We will start with Dr. Nordeen. Yes.
My question. Okay, well, I think when I'm being pretty practical about somebody who is starting to show signs of developing hypertension, diabetes, high cholesterol, their weight is an issue, I am oftentimes going to be looking to work with a nutritionist. I'm a big fan of functional medicine, trying to get to the root cause of illness. I find that, or I haven't found a practical way to really implement much of the holistic approach to patient care in my practice. I work for a traditional medical system where we have pretty limited time with our patients. And I don't know if I'm the best coach either, to be honest, in terms of nutrition. I know a fair amount, but I think sometimes if I have somebody who's super motivated to make changes, my best recommendation is going to be trying to find a functional medicine provider in the community that I can set them up with. If they're a patient who really needs medication and doesn't want to try medications, I might be inclined to see if they have seen a naturopathic doctor who might be able to work with them more on supplements. And I'm always, like I mentioned, looking at that screening for somebody who might need to work with a social worker or a counselor to work on their overall mental, emotional health. I think with metabolic disorders, those are probably my first go-tos.
It has always mattered more to me who the particular practitioner is that I'm considering making the referral to, more so than the letters after their name. So as a chiropractor for many years, there might be situations where I would refer to a chiropractor, but there were also situations, and I'm not limiting this to pre-metabolic syndrome here, but it certainly applies. You know, it might have been a dietitian, it might have been a nutritionist, it might have been a medical physician whose work in the nutritional and or psychological areas I had great respect for. And I don't mean to be leaving anyone out. There were situations in which I have referred patients to a whole variety of different types of practitioners, but the common thread in that decision-making process was always, is this a person whose integrity I trust, whose knowledge I trust, and who I feel really cares about their patients and is likely to be able to do a good job of motivating them to make the, in most cases, lifestyle changes that I feel are necessary. And by lifestyle, I basically, in general, refer to the big three, which are diet and exercise and some form of stress management.
Yeah, so again, I will say, I think it's different for every patient. It's difficult to say, I don't think anyone up here could say that. They would all say, well, this person needs these things and this person needs these. So the first place for me would be with their primary doctor, because generally as a non-primary care physician in this state anyways, I wouldn't make that diagnosis. And if I did make the diagnosis, it wouldn't sound anything like what they are familiar with, because I'm making it in a Chinese medicine terminology. So that doesn't mean that I can't recognize the Western diagnosis for students. That doesn't mean that, and it doesn't mean you're ignoring that diagnosis. It means you have to see that diagnosis in your own lens and then blend those two things together so that you can be effective. I often refer to NDs because most people are coming from their primary, so I like them to get a second look at that from someone else who may see it slightly different. The metaphor that I generally use, and it is apt in a number of different settings, but particularly here, is that a three-legged stool doesn't fall over. A patient needs to have three, and three isn't necessarily the number that they have to have, but they have to have someone who's primarily in charge, someone who sees it different, and someone who is able to bridge all of that together and help them move forward, because it can be overwhelming. The other part is, as we heard, motivational. Who's going to motivate them? Who's the quality person that can see it and that you trust, and who's the person who's able to motivate them? Because in the end, you aren't doing anything if the patient isn't. You can do all the right things. You can give them the best knowledge that your education you've paid for. You can give them everything, and if they don't pick it up and go with it, it's not changing very much. So you have to have that as well. So I think part of it is then assessing your skill set. If you are particularly motivational, then you can be that motivating force. If you don't know nutrition, then you should find the person who does, that you can trust, build a relationship, work with, get them with that person. These are the kinds of things I think that I generally think of when I'm referring someone. Who's going to give them the kind of care they need, right? That one, as Dr. Redwood said, cares. Two, as we've heard from everyone else, that is bought in for the patient and brings their expertise to bear for that. That's the whole approach that medicine, as we are evidenced by being here, is moving towards with this integrative model. No one person has the answers. No one should claim they do. And we should all be able to work together for the patient's benefit. That's the end game that we're looking for. Right?
I guess for as a naturopathic doctor and as primary care providers, we are skilled to do a lot of these things. So I actually find myself rarely sending people to other providers for the most part, because we are holistic providers and we try to do everything. And but there is one exception as far as I really enjoyed being a primary care provider as a naturopathic doctor in the state of Oregon, because we are able to, so especially working at NUNM, we have a Chinese medicine program as well, and we have acupuncturists working in our clinic, and I often will refer my patients to see an acupuncturist. We kind of talked about the mental, emotional aspects, and sometimes using acupuncture or Chinese medicine to kind of work with that energetic aspect of their mental, emotional things that they're dealing with. I think that's very powerful. And I suppose maybe, you know, some other, another naturopathic doctor in our clinic who's maybe skilled in GI conditions. That's something to think about too when we talk about metabolism, something that we talked about earlier. Are they absorbing their nutrients? As far as naturopathic medicine goes, we think about what causes disease, and we often think about inflammation. So if they have inflammation in their GI system, we have to address that, because that's causing inflammation in the rest of their body. It causes systemic inflammation. I think there's more to be said about this, but to really answer the question, I would probably refer to Chinese medicine practitioners in our clinic, and then maybe somebody who's more skilled in naturopathic gastroenterology.
Great. Okay, next question. And Dr. Redwood, we'll start with you. In your opinion, what are some potential etiologies for pre-metabolic syndrome?
We skipped question 3.
Yes. Yes, we've skipped around a little bit.
I
We've
would
got
like
some-
question 3.
All right.
Question 3, for those of you who do not have the play-by-play scorecard in front of you, goes as follows. What is your number one focus with these patients to prevent pre-metabolic disease from advancing, and how do you address treatment options with these patients? This question allows me to speak to nutrition. I think that rather than leave you with some really amorphous general ideas of, yes, pay attention to nutrition, I would like to bring to your attention the evolution within the American Diabetes Association over the past 15 years of how they have approached diet. If you go back to around 2003 or so, there was an ADA diet. It had limited portions. It had you eat, be sure to have this much of this and that much of that. At a certain point in the intervening several years, they made a change, and by the way, I am not endorsing their corporate sponsorships, all of the recipes on their website. I'm talking specifically to their evidence-based nutritional dietary pattern recommendations. They decided that research was showing that there were a number of different dietary patterns which were, in their words, modestly helpful for people with diabetes, prediabetes, metabolic syndrome, and so on. So I want to mention what those are. They have a list. It's not a long list. They are the Mediterranean diet, the DASH diet, the dietary approaches to stop hypertension, vegan diets, vegetarian diets, low fat, and the last one added, because they had said no to this prior to certain research coming through, the low carbohydrate diet. What they also say, and I think there's some real wisdom in this, and it in some ways pains me to be so complimentary of an organization that I have many problems with. I would say I admire, first of all, the fact that they recognize that in health and healthcare and healing, most questions have more than one correct answer, which is, I would say, for me, the single most important thing I learned in my years in practice. They also say that it's very important to take into consideration the preferences, values, and if relevant, ethnic traditions of the particular individual you're dealing with. Because frankly, as was mentioned earlier, unless we are suggesting something that a patient is willing to do, we're not going anywhere. So I would encourage you to look into the research, see whether you agree with the conclusions they've reached, see whether you think something should be added to or subtracted from that list, but be aware of what research evidence has demonstrated as being, first of all, not harmful, but preferably helpful. And on that summary note, I will pass it on.
So, number 3, number 1 focus, I think it is this lifestyle, this diet. And diet is a loaded word, I would say, because as Dr. Redwood was just saying, everybody that comes in patient-wise, remember, one of your goals, I would say, is to turn that patient into someone who is actually in charge of their own health care as opposed to you're in charge of their health care. They are in charge of their life. They're the one living it, so they're the one in charge of it. So empowering them, I would say, is the most important thing. Now, separate from that, when they come in, what do they want? What's a good diet to eat? Well, how the hell do I know what the good diet for them to eat is? Because everybody needs a slightly different. What works in this person doesn't mean it's going to work in this person. What works in this ethnic group is not going to work in this. The Mediterranean diet for these people works great. This works for these people. Some people, vegans, thrive, some don't. Some people eat nothing but protein and get by. Some people, become too etheric without carbs. There's no way, from my perspective, that you can say, this diet is the one. So then, how do people figure out what the diet is that's their one? That's part of the trick, right? There isn't one thing. So how do we do that? So one, what do they eat? How do they eat? When do they eat? Those types of things would be the primary focus that I would have. And what makes them feel good and what doesn't can be sometimes as simple as that. Every time I eat this, I feel fine. Every time I eat these, I don't feel fine. Okay, well, don't eat these then, right? It can be simple on some levels. And people have to be willing to experiment. But how do you get them to do that? Because if you're going to say to someone, change this, and oh yeah, and this, change that by next week. Also, I want you to exercise. I want you to not stress out. Do some yoga, do some qigong, do this thing. I want some mindfulness meditation. You should be going to bed early. You want to get 8 hours of sleep. You should not be stressed. You lost that patient somewhere back around number 2 of the things you were saying because you're telling them they want to do that. My question as a patient to the doctor would be, are you doing that? And how easy is it for you to do that? So I think there's this another level of complexity. We come in as these wide-eyed clinicians that we have some way that we can change them. The change is actually them changing. We can just present a menu of things that they can utilize. How are they going to move? How are they going to feel with all of that change? What are the things that functionally works for them to get rid of stress? Some people, patients I have, they're stressed out, they go run. Other patients, if I tell them, hey, you know, running works for getting rid of stress, they are like, you got to be kidding, I'm not running anywhere. Right? I have a bad knee. So that's not going to work. So I think we have to get away from this cookie cutter, this works for everyone, and then meet the patients where they are, have a wide and broad scope of knowledge that we are continually upgrading and learning, and then rely on a team of people that can offer things that we can't. This, I think, is how I tend to focus on treatment for people. And then give them, like you would ask them to eat, bite-sized amounts. Don't eat the entire thing at one bite. Just do little things. You know, I often use this with students. If a patient comes in and says they have ice cream 7 nights a week, it's probably not likely they're going to stop eating ice cream. So if they stop eating it 1 night a week, you've already made, if you, just from a mathematical perspective, you've made a very large change in the span of a short amount of time. So how can you, now that's not enough change, of course, we all know that. 6 pints of ice cream a week, that's still a lot. So you still have to work with them, but at least you are getting them willing to make it, the change, and make some progress. And you can, that's the thing, people have to be able to see, one, that progress is possible, that they aren't disease-oriented, because everybody comes in and will tell you what disease they have. Half of your treatment is getting them out of the mindset that they have a disease, and not just a thing that they can shift in themselves, that they are empowered to change. Right? So these are some things that I think we can kind of focus on.
I totally agree that it's up to the patient to make those changes, or the client, or whoever you're working with. As far as, I've had somebody come in and say, thank you, Dr. Chan, for everything you've done for me. And I said, no, I haven't really done anything for you. All I've done is guided you along the way. You're the one who's made the changes. You're the one who's doing the exercise. You're the one who's eating a great diet. So I think maybe, once again, finding the person to coach that person through making those changes if you're not that person. I guess going back to that, the question is, what's the #1 focus? I would agree that diet would be the one to start with. People who are in my class know that I have this beautiful colored picture from the American Heart Association, and they have these 7 parameters that they look at for what they define as ideal cardiovascular health. And if you look at this chart, the green means we're doing good, yellow means we're, could use improvement, and then red means that's an area that lots of people need to work on. And 76.8% of people are in this red zone, and 22.9% of people are in this yellow zone. So 0% are in the, there's nobody in the green zone if you look at this chart. So if I had to choose one thing to start with for patients, it would be the healthy diet. Granted, once again, this is from the American Heart Association, and they have their own definition of what a healthy diet means. But I think, their definition of a healthy diet is different from our definition of a healthy diet as far as from a naturopathic standpoint. But I think even if people aren't meeting their benchmark, then they're definitely not meeting ours.
I think you guys have really covered this question really well. I guess I would just add one very small thing to it and say the focus for me is going to be hopefully whatever we agreed on in talking about what the person's willing to work on. And then just a small bit of advice that patients usually seem to tell me is helpful is writing it down for them. Like you alluded to, if you've gone over several different things, and most visits you have, this could go for whether you're giving somebody some instructions about stretches or exercises or dietary changes or whatever it is, to write something down for them so that they can look at it again later. And maybe they left your visit in a hurry, did a lot of other things in their busy life, and then found their piece of paper a week later and went, oh, I didn't do any of these things that we had talked about. Okay, what's one of the things I could do? I like really simple solutions too. Sometimes I find people that don't eat very well. If I can tell them something simple like try to eat less processed foods, and maybe one way to do that is to make sure you add 1 cup of vegetables a day. Give them something tangible. Give them a real goal, something that they agreed to though.
Real quick, I just wanted to add something. One of the things she brought up is, what if you give the person the best plan in the world and they come back and one didn't remember it or they didn't do it? What do you think that person feels? Right? How do you think they feel? How is the diet going? I didn't do any of it. I ate 7 pints of ice cream this week. Okay, well, how are we going to approach that as clinicians? Right? If you approach that from anything other than you're doing fine approach, not really fine, but you can't approach that from a shame, you didn't do it, because that's not going to help. So I think it just bears one little piece of thing there. When people do come back, no matter what they've done, you are still the motivational force. I know that I should exercise. However, I often don't. Me, this guy right here. So I know what I should do, and I also know what I do. So you have to recognize that the patient is in that boat as well, and how are you going to help them in that boat?
Just to add something briefly to that, as time went on when I was in practice, I asked earlier and earlier in the initial interview with the patient, what are your goals in coming here? Because we need to be addressing, it's become a cliche, patient-centered outcomes, patient-centered goals. Sometimes we may think that that they're probably wanting to accomplish this for that reason, and sometimes we're right, but sometimes we're wrong. The way to find out, ask the question.
Okay, and on that same line of thought, I've gotten a couple of questions from the audience, basically around the same subject of if the patient isn't making the changes, then how do you instill those changes in a patient that's resistant to changing their lifestyle, what are the core modalities that you would suggest for that patient to change? We're back with Dr. Berletich.
You know, I think if you give them the change and they don't make it, you have to find in where they have done well and highlight that. It's not much different than anything else in life. It's if you focus on the places where you can see that they did some change, or if you can make a slight change. Your treatment helped with this. It didn't clear up the thing that they came and wanted treated, but this is better. You know, whatever, they have chronic headaches, but they also don't sleep well because of that, but now they're sleeping better. Well then, even though the headache hasn't gone away, something has changed, and you can see it. Even if they haven't made every change you suggested, where do you stay on the positive? Where was that thing that you did? And really talk to them about the process, because there isn't a single patient, whether they are in full-blown metabolic disease or in pre-metabolic disease, and I would ultimately say everyone's in pre-metabolic disease potentially, then, so that we can avoid any kind of like labeling, right? We're all in that boat, okay, great. But no matter where they are in this, wherever they are, you didn't get there overnight, and you will not get out of it overnight. The only thing that got you into it was habitual activity. The thing that will get you out is habitual activity, and until these kinds of things that we're asking them to do become habitual, it will be difficult, and that's fine. Difficulty isn't what we're trying to avoid. I think we have to prepare patients for that. If we can get them to realize that, that will be helpful.
I would agree about it's more about the habits. So if I had to choose one thing, I would choose exercise. That is, I wish we had a treadmill over at NUNM. We used to have, well, I used to work over at the Center for Natural Medicine, and we actually had a treadmill there where I actually worked with students to have patients do exercise. And that was great because then we could safely teach the patients how to exercise, first of all. Second of all, they felt like they had to come to their doctor's appointment and not, oh, I have to go to the gym. It's, oh, I have to go see my doctor, and my doctor's going to help me with exercise. So I liked that a lot, and once they got to a place where they knew how to do exercise on their own, we gradually weaned them off. But it also, there was kind of a social aspect of things, because I would see these patients every week. They would come in for their exercise, and back to, as a naturopathic doctor, we can be primary care physicians, and then we can actually bill insurance for therapeutic exercise for our patients. So then the patients wouldn't actually have to pay for their exercise therapy with us. It would be paid for by their insurance. So I guess that would be my answer, is exercise. Getting them into those habits, and then kind of weaning them off once they're at or weaning them from seeing you, not weaning them off of the exercise, but getting them to a good place where they're doing it on their own.
At the risk of sounding cynical, I would say, in my experience, some patients aren't ready to change. And I think I'm going to do more damage for those people and for myself as a practitioner if I try to pour the same amount of energy into every single patient's lifestyle changes talk, so to speak. So piggybacking off of what Dr. Redwood said, I think it's so important to always check that what I'm talking about isn't my goal for the patient, that it's the patient's goal for themselves. It's very easy for me in any given visit to desperately want the patient to want to talk about their diabetes and blood sugar control. And if I've tried to engage on that topic multiple times and they're not engaging, and instead they're telling me about their neck pain, I need to really check myself and talk about their neck pain and figure out if I need to send them to a chiropractor to start feeling better, and say, when you're feeling better, come back and see me, and we can talk more about the diabetes if you would. But I don't want patients to stop coming in for care because I had an agenda that didn't line up with what they needed, and I was too busy thinking I was supposed to give them such and such information and make them do X, Y, and Z to get better, and they really weren't there. I also think that it's nice when patients don't want to make a change, if they do seem to be enjoying the service you're providing them, to allow them to continue to come in, because they may need time, and they may be the person, you may be the person that they're going to come back to and ask for help on a certain issue when they are ready for that change. It's hard to not get discouraged sometimes with patients, but yeah, try to remember that people change at different rates and have different priorities.
It's hard to know what to add, and I'm also seeing that we are close to out of time. I would say that I would reemphasize that finding, assuming it exists, some kernel of positive action that this patient has put into effect and trying to build on that. I mean, it's, yes, I'm so glad that you were willing to give up, 2 teaspoons of ice cream this week. I'm sorry, I'm overstating that. But building on the positive is important, being a good listener is important, and not having preconceptions as to exactly what this person needs to do at what point and in what order, I think it serves the patient's needs in ways that, that serve us well as practitioners to implement.
Great, thank you. And it does look like we're about out of time. So just a quick thank you to everyone for coming. We really appreciate it. And if you need any continuing education or CE credits and you've come in a little bit later, there's a sign-up sheet over by registration. There's also a raffle at the far end that helps support free events like this.